Bismillah ar-Rahman ar-Rahim. Asbestosis. Definition of asbestosis. Asbestosis is a chronic interstitial fibrosis resulting from asbestos inhalation. Causes of asbestosis. Factors affecting disease development include the following: degree and length of asbestos exposure, a clear dose response relationship exists, usually seen in workers with many years of high exposure, although may follow a very high exposure of short duration, resulting in a shorter latency period. Fiber type. Amphibole fibers are probably more fibrogenic than cryosutile, although most exposures are mixed fiber types. Cigarette smoking increases the severity and rate of progression of asbestosis. Latency period from first exposure to clinical disease is usually at least 15 to 20 years and may be more than 40 years. Clinical features: insidious onset of breathlessness, dry cough, and bipedal late inspiratory crackles, clubbing in 40% of cases, and the condition may progress to respiratory failure and cor pulmonale. What is the differential diagnosis of asbestosis? Differential diagnosis of asbestosis includes other causes of interstitial fibrosis, particularly usually interstitial pneumonia. What are investigations done for diagnosis of asbestosis? Investigations of asbestosis include chest X-ray, bilateral symmetrical reticulonodular pattern primarily affecting the lower lobes, peripherally, which may extend upwards to involve the mid and upper zones, may progress to honeycombing lung, and massive bilateral upper lobe fibrosis without lower lobe involvement is rare but well described. Associated pleural thickening or plaques may be seen and suggest a diagnosis of asbestosis rather than UIP. Classifications is based on size, thickness, and profusion of asbestos and chest X-ray insensitive to early disease and may be normal in 15 to 20% of symptomatic biopsy proven asbestosis. Again, chest X-ray insensitive to early disease, that is to say, may be normal in 15 to 20% of symptomatic biopsy proven asbestosis. HRCT is more sensitive than chest X-ray and is abnormal in 10 to 30% of cases with a normal chest X-ray. Features include basal ground glass opacities seen early in the disease, parenchymal bands, subpleural curvilinear lines and opacities, interlobular septal thickening, signs of fibrosis, traction bronchiectasis, loss of lobular architecture, honeycombing in advanced disease, and pleural plaques. Pulmonary function tests are classically restrictive with reduced lung volumes and transfer factor, although obstructive or mixed pattern may also occur, perhaps reflecting asbestosis induced small airway disease. Analysis of sputum or bile may demonstrate asbestos bodies, although sensitivity is limited. The finding of interstitial fibrosis in the absence of asbestos bodies on or lung biopsy makes asbestosis unlikely. Asbestosis demonstrates fewer fibroblastic foci than with UIB pattern fibrosis, although visceral pleura is frequently mildly fibrotic. Analysis of maternal analysis of material for asbestosis bodies is only very rarely indicated, usually for research or for litigation purposes. In general, chest X-ray and HRST show only limited correlation with physiological disease severity. Diagnosis. Gold standards. Gold standard is pathological demonstration of fibrosis with mineralogical quantification of asbestos bodies. The Colleague of American Pathologists and Pulmonary Pathology Society have defined a 5 point scheme for grading asbestosis. Grade 0, fibrosis confined to bronchial walls, and grade 1, fibrosis extends only to first tier alveoli. Grade 2, fibrosis involves alveolar ducts and second tier alveoli. Grade 3, fibrosis of the alveoli between respiratory bronchioles. Grade 4, honeycombing. In practice, histology is rarely required and a diagnosis can be made on the basis of history of significant asbestos exposure with appropriate delay between exposure and disease, and radiographic evidence of fibrosis, particularly when seen with pleural plaques. Treatment. No pharmacological treatment is of proven benefit. A supportive management, including supplementary O2, is required. Influenza and pneumococcal immunization, smoking cessation, compensation if exposure was occupational. The prognosis varies widely after removal from exposure. Progression occurs in 5 to 40% of patients over 10 years. Progression is faster following greater exposure, although rapid progression over 1 to 2 years is unusual and more in keeping with usual interstitial pneumonia. Fewer chest X ray opacities after exposure are associated with better prognosis and increased risk of developing lung cancer. That's all. Thank you.